Okay, so for the last 15 minutes, I'll give you a flavour of some of the organisations and some of the sorts of activities that have been going on in the UK using cost-effectiveness information. So, NICE, first of all, the National Institute for Health and Care Excellence, they, over the years, been in existence since about 1999. Over the years, their remit has expanded and expanded. Their resources have gone down and down, but that's called productivity increase. And they do a huge amount of activity. You might have come across clinical guidelines they produce. The area that's of perhaps most relevance here is what's called technology appraisal. And this is decision making around new health technologies, predominantly new drugs. Essentially, what NICE is doing with respect to assessing new drugs is reviewing clinical and economic evidence. And the issue is this: how well does the new medicine work? And given how well it works, and given the price we're being asked to pay, how good value for money is it? So, first of all, does the evidence suggest it's effective? And then second, given the cost to us of the new drug, is it good value for money? So, NICE Appraisal Committee makes recommendations on these new technologies. It has two categories of guidance. It either recommends or it says not recommended. If it recommends exactly what or for whom and when. So for example, it may, in approving a new drug, it may restrict the patient group, or it may introduce a stopping rule that this new drug will be available for 6 courses of treatment, but then no more. The health professionals in England are expected to take NICE guidance into account when exercising their clinical judgment. Now, all that means is health professionals can do what they like. And as long as other health professionals, their peer group, don't think the behaviour is strange, they're fine. On the other hand, for the NHS as an organisation, a NICE positive recommendation is mandatory. So if NICE recommend a new drug or a new therapeutic approach, the NHS in England must make that available normally within 3 months. Individual clinicians can do what they like, but the system has to make the treatment available. NICE has a threshold, and it's been quite explicit that its threshold is a range, and the range is £20,000 to £30,000 per QALY. And it's had this threshold range since 2004, hasn't changed it, although I think it's fair to say at the start, near 2004, committees were tending to think of the bottom end of the threshold range, 20,000, whereas in the last few years, in effect, the threshold is 30,000. So while the threshold hasn't changed over time, the point where we put greatest emphasis has maybe shifted. So it is equivalent perhaps to the threshold rising slightly over time. There's a recognition, explicit recognition, that the QALY may not fully capture the health benefits. And that's one reason why committees might be willing to pay a bit more than the threshold value. The other situation is where the evidence is a bit poorer and the uncertainties are greater. In that sort of situation, perhaps a committee will be less likely to recommend a particular technology at any particular cost threshold. And this element here, this last one, is this example I mentioned with respect to cancer. There's something called supplementary guidance for life-extending end-of-life treatments, which was introduced in 2009. And they've revised the criteria a few times, but currently there's 2 criteria to be fulfilled. The treatment is indicated for patients with a short life expectancy. That's less than 24 months. And there's sufficient evidence to suggest that on average, patients could gain 3 months of life. So short life expectancy for the patient group, under 2 years, under 24 months, and evidence of potential health gain of an average of 3 months. And if those 2 criteria are met, the QALYs are valued more highly, and the 50 decisions so far that met these criteria have used a cost-effectiveness threshold equivalent to £50,000 per QALY. Now, every example of a short life expectancy, less than 24 months, and an expected gain of 3 months, every example has been a cancer therapy. But it's not all cancers, it's cancer therapy near the end of life. And so it's an example of just the opposite of what you're suggesting that you might favour or might expect, and that is this group of patients who are particularly ill, we're valuing benefits to them more highly than all other patients. The idea that's put forward is, excuse me, if you have a very limited life expectancy, that extra little bit of time to sort of put your life affairs in order, or you survive to see the baptism of a grandchild, or you see somebody marry, or whatever. These are the sorts of things that are put forward, are particularly important. And I'm not going to argue they're not, but every other patient group who don't meet these criteria, they also have things that are important to them. So I think it's quite a strong judgment to say that this group deserve more. It all came about because of politics. You won't be surprised. I haven't got time to go into the story for that, so I'll have to leave that.